Resorption. I'm going to try and do a quick presentation on resorption. The topic just does not seem to go away, and I want to limit the discussion to clinically what matters in terms, the types of resorption we're going to see that matter, that make a difference to us as restorative dentists. We're going to see quite a bit of external resorption, and very rarely, we're going to see internal resorption. And there are some other types of inflammatory resorption that have to do with trauma, teeth that have been reimplanted following trauma, that have to do with chronic endoabscesses, things like that. But let's limit this discussion to just external resorption, and internal resorption is what I'm going to call it. There's a lot of terminology in the literature on these things, but we're going to leave it at external and internal. And what do I mean by external versus internal? I'm talking about the source of the clastic cells that are eating the dentin. Okay, so there's some in resorption. There's some odontoclasts because they're eating dentin. We're going to call them odontoclasts here. This article calls them odontoclasts. So that's what we're going to call them. And something is telling these odontoclasts that it's okay to eat this dentin, even though it's otherwise healthy dentin. Something's turning the signal on when it shouldn't be turned on. If the source of the odontoclast is from outside of the tooth, that's external. If the source of the odontoclast is from inside the tooth, meaning the pulp, that's internal. So we could call it pulp-based resorption instead of internal pulp resorption, or external attachment resorption. External resorption, something is happening outside the tooth to tell these cells go ahead and eat that tooth. Now it's confusing because it can come from the outside, make a tiny little opening in the external surface of the tooth, and then go crazy on the inside of the tooth. And so people will look at that and say, well, that's internal. It's eating up the inside of the tooth. But you need to know the source of those cells is from external, from outside the tooth. And you need to know that because it makes a difference in the prognosis. Internal resorption is easily treated. You just remove the pulp, you do endo, and assuming the tooth is structurally sound, you're done. You've stopped the process. External resorption, a little muddier than that. And just cleaning up the inside of the tooth is often not going to do the trick. So let's go. Let me just point this out. This is a great review article from the Journal of Endodontics 2010. If you can't find it and you want me to post it, I could. The reason I think it's important to read this stuff, this will tell you what we do know about resorption, and it's quite a bit. We do understand the mechanism of what's happening. They do understand the histology of how these clastic cells bind and consume dentin, and why they don't consume the pulp if they're coming from external. They just get to the pulp and they stop. So there's a lot that is understood. Now the whys are not understood. There's a whole list of possibilities. But bottom line is, nobody really knows what turns on external resorption. So here's some of the suspects: trauma, bleaching, surgery, periotherapy, ortho. Look at these images. This is a pretty cool image. Okay, so this one pretty easily identified as external resorption because inside the pulp has remained intact. Look at the scan. This is a 3D scan. The pulp is normal. Pulp space is normal. Pulp space is normal. Everything's happening on the outside. But notice there's not like some big hole on the outside, at least not from this angle on this particular slice. But there is an external source for these clastic cells doing their damage inside the tooth. That makes it an external resorption according to almost every article you'll read about this stuff. So let's move on. A couple more cool images. Here's another one. Here's another one. If you do endo on this tooth, is this going to stop the process? No. Because it's coming from the outside. Depending where this lesion is, if it's surgically accessible, if the patient wants to attempt it, you could treat it. I couldn't treat it. I don't do it, but somebody could. Here's another, more slices. Anyway, you get the idea. This is a good article to go to. Here's another good article from Hapasalo, Endotopics. This is on internal resorption. I'm not going to spend a lot of time here. It's really rare. The odontoclastic activity is coming from the pulp, chewing up the inside of the tooth from the pulp. There's some cool images here. That's from Endotopics. Did I say that? Endotopics 2006. You can probably find this online. I think I did. I don't have a subscription to Endotopics anymore. Again, a lot of the histology. Look at all this detail on the histology. Don't ask me. I don't know what it means, but it means they know a lot about what's going on. We just don't know why. Although with internal, it seems to be precipitated by some type of trauma to the crown of the tooth, some type of coronal trauma, usually restorative. Probably using a crappy 330. That's probably what causes it. Dull burrs. Where are the images? Hang on here, guys. Okay, good image. Internal, because the source of the clastic activity is inside. We know that because we don't see a normal pulp space. We can't outline the pulp space. Okay, that's the simple one. That's the easy one. Here's another good image. Usually coronal to the resorptive area where the odontoclasts are chomping away. Coronal to that, it's kind of necrotic. The pulp's kind of degenerating. We think there's a microbial component in these cases. Not so sure with the external. When does the microbial component become a factor? Is it a precipitating factor? We don't really know. Or do the microbes just come along for the party once the party's started? We don't really know. I think there's a couple more images. These lesions can perforate all the way out. The tooth, they can cause such a massive defect that there's cavitation. Another one. Another one, there can be communication with the attachment causing a fistula. So in this case, probably got necrosis here, dead gunk here, perforates through the buccal plate, or maybe this is palatal, I don't know. Now they got a fistula, they traced it with a gutta-percha point, and sure enough, there it is. Okay, enough on that. Let's go to this article. This is a really cool article. This comes from Rick Schwartz, Bill Robbins, and Eric Rindler. These guys practice in San Antonio. These are private practitioners. I don't know if you guys know their names, but you've probably taken a course with them, or read a textbook that they've written, or read journal articles that they've written. But what's really cool about these guys, they're full-time, private practice. These are the types of people we should be listening to because they're awesome clinicians and they do it every day. They don't just treat a patient every now and then while they're teaching full-time or doing research. So this article has some really cool cases. They're calling it invasive cervical resorption. So what is that? That's external, invading the tooth from outside in the attachment. I'll go through these pretty quick. That's a beauty, huh? That's a massive, massive advanced lesion. Now, I want to tell you the reason this matters. If you think this is caries, if you don't recognize this as resorption, and you think it's caries, you're going to drop a burr in there, and this thing is going to bleed like crazy and freak you out. These are highly vascular. These are highly vascular. The blood supply here is not continuous with the pulp. The blood supply is continuous with the attachment, with the bone. Okay? So it's going to bleed like a stuck pig, and you're going to wonder, what in the world? How did I perforate? All I did was drop my 245 or whatever in there. All I did was drop a burr in there and started scooping around with a round burr, and holy cow, what's going on? Okay? So it's important to recognize this. Look at this appearance. It's kind of mixed radiolucent and radiopaque kind of all at the same time. These things are highly vascular and they will freak you out. So that's one reason to recognize them. Here's another one. This one is interesting. These images are 10 years apart. Oh, I want to say this article also from Journal of Endodontics, JOE. If you can't get it, maybe I can post it on this thread later. These are almost 10 years apart. Why did they do nothing? Because this is hopeless. This is, the structural integrity of that tooth is pretty far gone. That's a very advanced resorptive lesion. So the option, one of the options, and the authors go through these options. One of the options here is do nothing, extract when it becomes symptomatic. Okay, so patient opted for that. 10 years later, they still got the tooth. Pretty unusual. I've seen more often than not, I see these advance very rapidly. So that's what I tell patients is get ready, get your implant piggy bank up to speed, because that's probably where you're going sooner rather than later. But this is an exception and is an option. Now, if this lesion was very small and very accessible, then you would go forward with treatment, which is endodontics to support the treatment of the resorptive lesion. And I won't go too much into that, but that would be the preferred treatment if you catch it early and it's accessible surgically or internally. Here's a cool image. This comes from Marga. This comes from an endodontist in Amsterdam. She does amazing work if you've never seen her work. I don't know if this is showing up, but you can see this is the microscopic appearance clinically of external resorption, and the way it has these little penetration points, these little mixed areas of that's why the radiographs look mixed, radiolucent and radiopaque. So these bleed like crazy. At this point, no doubt she's probably treated this with TCA, trichloroacetic acid, is the treatment used to stop the bleeding in these cases and try to destroy these resorptive, these odontoclasts that are eating up the tooth. I just thought that was a cool image. So here's another case. Upper molar. This is a cool case because surgically this isn't accessible. So this was treated internally. I think this is Rick Schwartz treated this case, made access into the resorptive lesion, treated it with TCA, and probably repaired with MTA. I don't remember. But you can see here, the lesion was extremely hemorrhagic. That's what you need to know. If you think this is just decay and you drop a burr in there, get ready. It's going to bleed like crazy. So we need to know what we're looking at if we're looking at resorption versus decay. So you kind of need to get a feel for what these things look like. Another one, easily accessible surgically. It's kind of up high on the tooth. It's on the buccal. It's in an area of the mouth you can get to. Then definitely go in there and get it. Don't just watch and wait. Don't watch and wait one like this that's accessible and treatable. What's the recall on this one? I don't recall the recall on this one, but these will last. Here's a very heroic case they threw in just for fun Believe it or not, they treated this case and it lasted 10 years. But the reason they treated this case was, the reason they even attempted it is because this lesion is on the palatal. And so aesthetically, on the labial, it was favorable. There was no downside. From the labial, everything looked good. This is 9.5 years. This is at 9.5 years, and the tooth fractured not long after that. These days, of course, that's extremely heroic. We're just going straight to implant, and that's what the author says in the article. Let's just go straight to implant. They just put that in there because you need to know that these things are possible. So I hope that was some help with resorption. Another image of internal, and sure enough, the tooth's been restored. Almost always when you see internal, the tooth's been restored. And I'm going to leave it right there. Thanks.